A new knee will dictate how you move, hike, and live for the next 15 to 20 years. Yet many patients go into surgery without knowing exactly what hardware is being permanently placed inside their body. That is where we come in. I'm here with the best of health, your trusted guide to navigating over 50s healthcare decisions with clarity. To understand your options, we first have to strip away the jargon. A knee replacement implant has three basic pieces. First is the femoral component, a metal cap that covers the end of your thigh bone. Below that is the tibial component, a metal plate resting on top of your shin bone. Between these two metals sits a plastic spacer, which acts as your knee's new bearing surface. Recognizing these three parts is the first step toward evaluating the specific choices your surgeon will make. Your path to surgery heavily influences those choices. On the NHS, strict clinical protocols and your surgical team will select the implant for you. This flowchart shows how that contrasts with the private route. While the NHS follows a direct line to standard care, the private route branches out, offering direct input on materials, fixation methods, and even robotic surgery. No matter which path you take, understanding these variables prevents choice paralysis. You stay at the center of the decision, aware of what is happening to your own body. The best option is rarely the newest or most expensive technology. It is simply the one that matches your specific age, bone quality, and activity level. To find that match, we need to weigh the three major trade-offs of modern implants: the scope of the surgery, the materials used, and how they are attached. The first major trade-off involves how much of the knee joint is actually replaced, starting with the total knee replacement. This quadrant chart plots recovery effort against long-term durability. The total knee replacement sits high on durability, but requires significant recovery effort. It is the primary choice for 90% of UK patients. Despite a larger incision, it provides the most reliable long-term durability. For patients with damage isolated to one part of the knee, a partial knee replacement serves as a specialized alternative. On our chart, it drops much lower on the recovery effort scale. You benefit from a smaller incision, faster recovery, and a more natural-feeling joint. However, partial replacements carry a higher revision rate over 15 to 20 years. Choosing this path means trading a statistical guarantee of longevity for a faster return to normal life. Ultimately, this choice balances the immediate benefits of a faster recovery against the decades-long durability of a total replacement. Once the scope is decided, we look at the materials. The Best of Health research team analyzed National Joint Registry and NICE data to see which materials actually hold up best. Across both the NHS and private sectors, the standard bearing surface is metal on polyethylene. Modern highly cross-linked polyethylene is incredibly durable, meaning paying for upgraded materials is rarely a clinical necessity. Alternatives like ceramic or oxidized zirconium exist, but they are primarily used to solve specific issues, such as severe metal allergies. Then there is the design of the movement. This is the debate between standard fixed-bearing implants and advanced mobile-bearing implants. This bar chart compares their 15-year survival rates. Fixed designs lock the spacer, while mobile designs allow slight rotation. But look at the data. Despite more complex mechanics, 15-year survival rates are practically identical. Advanced movement hasn't resulted in a longer-lasting knee. While rotating materials may sound more advanced, standard fixed metal on plastic remains just as effective for long-term survival. The final technical choice is fixation, how the metal components are permanently attached to your bone. The UK standard is cemented fixation, where medical-grade cement instantly locks the implant to the bone. For the majority of patients over 55, the pathway leads directly to cemented fixation because it boasts the lowest revision rates in the country. The alternative is uncemented fixation, featuring a porous surface that natural bone grows into. As the flowchart shows, this is reserved for a specific profile: active patients under 55 with exceptional bone density. While biological integration sounds ideal, uncemented implants lack the immediate day-one stability provided by cement. Fixation isn't a matter of preference, it is a matter of biology. Your age and bone quality are the final deciders, and for most over 50s, cement remains the champion of longevity. While these technical details are complex, it helps to look at the broad success of modern knee replacement as a whole. This line graph tracks the high survival rates reported by the National Joint Registry. Approximately 96% of total knee replacements are functioning perfectly at 10 years, and 90% are still working well at 15 years. Remember that beyond the implant type, success depends heavily on your own weight, activity level, and the experience of your surgeon. To map your scenario, if you are an NHS patient, you will likely receive a cemented, fixed-bearing total knee replacement, the proven gold standard for longevity. If you are going private or are in a younger age bracket, use your consultation to discuss if partial or uncemented options better suit your specific activity goals. To advocate for yourself, bring these specific questions to your consultation. Ask if you are getting a total or partial replacement, what the bearing material will be, if it will be cemented, and how many of this specific implant the surgeon has fitted. This video is for information only. You must always consult your GP or a qualified healthcare professional before making any health decisions. For more guides to help you step into your surgery with total confidence, visit us at thebestofhealth.co.uk.